Hi, this is Judy Saalinger from Lasting Recovery, San Diego's premier outpatient alcohol and drug treatment center. And today we're talking about
I actually have two goals today. Goal one is to have everyone leave with maybe 60% of an understanding of what the scientific enterprise has taught us about buprenorphine and opiate dependence in the last decade. The second goal is really to hear from people what your experiences have been. Part of my message about buprenorphine is that any treatment for any problem that we dispense, that I as a physician dispense, or that therapists dispense, has risks and benefits. I was thinking this morning, you always have the best thoughts when you're in the shower. I was thinking that there's a metaphor, and see if you can bear with me, between buprenorphine and lithium in a way. I would posit that my clinical experience and what the research would show is for some people with the brain disorder called opiate dependence, buprenorphine can be a stabilizing force on their brain. But anybody who's heard about this miraculous drug called lithium knows that there can be disasters with it. So I tell patients all the time, I don't have quick, easy, clean, risk-free solutions to most of life's problems. We as humans have complicated problems that have solutions that are fraught with costs and risks. So that's kind of the ground we're playing in today. Before I go any farther, I wanted to acknowledge Dr. Kentigan and Dr. Lamb and I have done are in the process of doing two studies. One you'll hear about. We surveyed Suboxone providers in the community to see what attitudes were in things, because about a year ago I asked myself, gosh, it seems like people are doing different things. What's the community standard? And then this survey, I wanted to see how the attitudes and practices and thoughts about buprenorphine of the providers in the community, the people who prescribe, match up with the people who do the hard work and see, right? Because there's often a mismatch, and that's kind of funny too. Sometimes I make the analogy, historical perspective is so helpful. There was a time in the 50s when the solution for example, mood disorders was one of the big solutions of psychoanalysis. And if people would have been, if we would have thought that we were recommending people to be on antidepressants long term, that would have been anathema. So we evolved, don't we, I hope, in our scientific understanding. That's the difference between science and religion in a sense. We're happy to say, oops, wrong about that, let's change course, oops. And part of the opiate dependence problem is an oops. So we'll get to that. Would you go to the next slide, please? So here's my contact information. What's in your handouts, the little things you're going to scrawl notes on, I have much more information here. I was trying to be green and not put all this on there. If anybody has any questions, wants a study, wants my whole talk, which actually won't transmit well, please contact me, call me, whatever. I'm happy to answer questions. And so relax and don't worry that all the slides aren't in there. Next slide, please. Okay, so let's frame this. There's a problem with anecdotes, and there's a good thing about anecdotes. These are all people who died of overdose, and it spans time, right? Sid Vicious, his mother actually was his dealer. I had wanted to give some female names. Apparently, all of opiates were related with all of these poor folks. And then here's our current, So the problem with the good thing about anecdotes is they arrest our attention because it's a real human story. The problem with anecdotes is they aren't really data from a scientific perspective. We'll get into that more later. So let's do next slide, please. And I apologize, I had to bring a human slide advancer today. Judy was talking about the hot aspect of this. This is actually I think a poorly done coverage of the buprenorphine crisis. I think it's poorly done because it's very anecdote-driven. There's not a lot of information about the data. But this is a recent New York Times story, gives one perspective. Something I learned from this that I'm going to speak to is across the country, people with the MD behind their name have actually contributed to giving buprenorphine a bad name. We'll talk about that. Next slide. So here's where we're going to go. And just flip through these, please. Okay. So we're going to talk about opiates and the problems because we as a species have loved opiates and hated opiates for a lot of our time on the planet. So we're going to talk a little bit about opiates to orient ourselves. We're going to talk about the opiate epidemic. And the opiate epidemic is a complex problem. This is why I'm glad I'm a liberal arts graduate, because we're used to, it's a complex problem. We're human mammals, and we walk around and create funny problems. And I'm owning that my profession has been a big part of this recent problem. Next time. We'll talk a little bit about history again, because I think it's important to see ourselves as an evolving process. Next. And recent statistics. One way to think about the current opiate epidemic, and I say current, although I think there's reasonable evidence that once you soak a young person's brain in powerful chemicals, it doesn't become recent. They get that for their lifespan. That's the concerning and worrisome part of this epidemic and this problem. But this is collateral damage. A lot of these teens are collateral damage from these complex forces, and we'll talk about that. Then we'll talk about some solutions, and I put this term in quotes, right? The solution for addiction, of course, is to find a different species, right? Because our brains are wired such that this is, right? So there isn't a solution per se. It's like, what's the solution for the throes of being in love? And there's no solution, but we can hopefully help people with some problems. Next. So we'll talk about the history of solutions next, and buprenorphine basics. And it's important you understand, some of you may be experts, some of you not so much. It's important you understand the chemistry and the biology of this drug. Next. We're going to look at our study of local providers, because one of the other things in this New York Times article is interesting. There's differences in communities, have different standards, different practices, different ways people roll. So, it's helpful to see the national issue and then also to know what people are doing locally. Next. And then again, I want to have a little free-for-all for people to throw out and challenge a lot of the stuff I said, 60% of which may not be accurate. Next. Okay. So why is your tax dollar supporting these guys with these big guns to walk around this flower field?